So welcome to the CERSI 2020 Summit, to the IR and Global Health session. It's a great pleasure to organize this session again. It's the second time we're doing this, but CERSI's, we are committed to support global health initiatives and the development of IR practice in low-income countries. So it's a pleasure to welcome Rosemary Bianamia. She's a consultant radiologist in Uganda. I would like to welcome Fabian, who is a senior IR fellow in Yale and a good friend of mine. I would like to welcome Andrew Kesselman, who is one of the IR leads in RAD-AID organization, doing some great stuff all over the world. And we hopefully we're going to welcome Dr. Niloyo from Nigeria, who's going to talk about IR in Nigeria. I'm going to start with Rosemary, and she's going to tell us more about the work we've been doing in Uganda, setting up an IR service there. Thanks, Rosemary, for joining us.
Thank you very much, Gregory. Good evening, colleagues. Greetings from Uganda. It's a pleasure being part of this program. I want to talk about what we've been doing in terms of IR in Uganda. We have made some little progress and we are proud of it for sure, and we hope to make bigger strides. Now, in Uganda, we think it is justified to have IR training because there's need for interventional radiology in Uganda. And the current training programs do not offer comprehensive IR training apart from one course unit at postgraduate level. There's also need to build local capacity as well as improve on the infrastructure and equipment. Then we believe that if we train locally in Uganda, we shall build a sustainable IR service. We can move to the third slide. The efforts to IR training in Uganda started with a visit of Dr. Gregory Macris in November 2018. And during that time, he had interfaced with the members of the department and the hospital, the Malaga National Referral Hospital. But apart from that, we've had other workshops where we've tried to sensitize our own postgraduates and other radiologists to gain interest in interventional radiology in Uganda. But as a way of awareness, we made sure when Gregory was around, we introduced him to the College of Health Sciences leadership, to the Ministry of Health leadership, and the Heart Institute, the only institute which has a cath lab in Uganda in the public sector. And we also made him visit some of the private institutions that could be partners in the IR program. Please move the slides. Now, talking about the current progress. Next slide, please. Next slide. The current progress. Last year, one radiologist was in India for an apprenticeship for a whole year in a place where they do a lot of interventional radiology. That radiologist is one of the lecturers at Makerere College of Health Sciences. And at the beginning of this year, a benchmarking visit was made by 4 radiologists from my institution to Muhimbili in Tanzania. Apart from that, we've also drafted a training curriculum for the Makerere College of Health Sciences, and this will be offering IR at doctoral level. The curriculum is already submitted to the institution and awaiting approval. We've also developed a survey protocol on awareness of IR in Malaga National Pharaoh Hospital, and we are awaiting approval of this by the Institutional Review Board so that we can administer that questionnaire. So we hope that it will give us a lot of information that will help us in the planning of this program. Now, next slide, please. When we had this team which visited Muhimbili, they came back with really very rejuvenated about the starting of the program in our country. They realized that IR training can start gradually because Muhimbili has done it so. And they also noted that we need a lot of support to establish IR training, especially from IR practitioners individually and also associations, both in Africa and the rest of the world. They also noted that there's need to have a dedicated and committed IR team in the department, not only of radiologists, but anesthesiologists, IR technologists, and the nursing staff. So they themselves, as the 4 radiologists, we've identified them to be the leaders in this, and they've ably taken on the responsibility. Next slide, please. Now, currently, I wish to say, as given the privilege of being the Deputy Executive Director of Malaga National Pharaoh Hospital at the beginning of this year, and this hospital has been under renovation and remodeling of part of the hospital. And the pictures you see there are the equipments in the new refurbished hospital, which we hope to utilize. But currently, that is the hospital where we are taking care of COVID-19 patients. Next slide, please. I also wish to share with you some slides showing what our trainee who was attached in India for an apprenticeship for 1 year, the work he has started doing. But this has been done in one of the private facilities within Kampala, which has installed a cath lab. So that shows that we can use the public sector and also the private sector in RI training. Next slide, please. With all this, we still see that there are challenges right now. Of course, with COVID-19 pandemic, everything is a little slow. The design and approval of the curriculum takes time. And of course, also because there are fewer meetings at the university and less staff on their desks, the approval of this curriculum may take a little bit long. Having only one cath lab, which is in the Heart Institute at Malaga Hospital, and the unit being busy, that means we have less chances of having space in that cath lab, but we hope that we can convince the ministry to install more cath labs, but we need to start with what we have. There's also the issue of who will sponsor, who will finance the training of the trainers. And also these trainees need mentorship, and to have also a service which is sustainable, we need to be sure of the financing, both for the trainees and also for the equipment and the consumables. But we think there are opportunities, both locally in terms of the available equipment, we should start with what we have. And then in the region, partner with Muhimbili, which is already a little bit ahead of us, and they offer us support of trainers. And also we want to appeal to the international bodies for trainers, from associations, from manufacturers, for equipment and consumables, as well as advocacy for RI training in Uganda. Lastly, I wish to conclude by saying that starting RI training in a resource-limited setting can be quite challenging, but I think we are willing to work as a team and solicit for support and improvise so that we can make this dream a reality. I thank you for listening to me.
Thank you.
Rosa?
Thank you, Dr. Baranima, for your interesting presentation. Are there any questions from the audience? So maybe I think we need to break the ice, and I have just a curiosity to ask. What are the fields of application in which you think the use of interventional radiology in Uganda could be the most promising? The field of application of intervention.
The field of application, of course, involves all areas. We have a high maternal mortality rate due to postpartum hemorrhage, and we think interventional radiology embolization would be very helpful. We have a high rate of malignancies, GI malignancies. We think embolization, chemoembolization and stuff would be very helpful. We have a lot of road traffic accidents, and of course, in such cases, hemorrhage is normally the cause of death, and still interventional radiology would be very helpful. The other area, an example I know, is of the gyne cases, cases of endometriosis for uterine fibroids are very highly prevalent, and this would also benefit from interventional radiology. So, and just to mention but a few, we have cases where we need to do renal interventional procedures, biopsies, and drainages, you know. So really the spectrum is big, but I see more of body interventional radiology, but I think also neuro and vascular interventional radiology has a high demand.
There are no neuro interventions taking place now in Kampala, right, Rosemary?
No neuro interventional radiology taking place.
That was my impression as well. I think that one of the main purposes of this session is to help people understand the kind of lack of services that we have in low-income countries, and especially in the African region. And it's very easy to misunderstand or to not appreciate the extent of the problem. I mean, it took me a travel to Kampala to really appreciate the magnitude of the problem. And you know, when we're talking about lack of interventional radiology services in the UK, when we have quite a few interventional radiologists around, imagine the scale of the problem when you're talking about a 40 million people country like Uganda with absolutely no interventional radiology services. And when you know, I mean, it's not only about the complex stuff like EVARs and peripheral arterial walk and all these things. I mean, we're talking about the lack of simple interventions like CT guided procedures, nephrostomies, PTCs, and all this that can be life-saving, and at the moment they are desperately missing from these regions. There's a lot of work to be done. I mean, fortunately, organizations like SIR, CERSI, they are, and of course RADAID, they're working in order to change this. And fortunately, the last few years there has been a lot of progress. And you're gonna hear more about this from Fabian and the rest of our panel about their efforts.
Yeah, Rosemary, I had one more question. The curriculum that you submitted, is that for 1 year or 2 years?
The curriculum which was submitted is for 3 years. So you
3 years.
do 2 years with the dissertation, and that's why you get a doctorate.
Okay, and that's after 4 years of diagnostic radiology or after 3 years of diagnostic?
After 3 years of diagnostic radiology.
So it would be total of 6 years.
Yes, you can give yourself a break in between.
Yeah, no, I mean, it's good. I mean, that's the same way we have it in the US, only that here we don't have the dissertation, but we have like intern year, and then we have 3 years diagnostic and then 2 years IR.
Okay.
Awesome. I think Rosa will have to move on, and we can, if we have time, we can discuss a bit further.
Next speaker, that he is Dr. Fabian Lejgov. He is working to establish a radiology service in Tanzania. And his project has been recently awarded funding through RSNA, and he will talk about IR in Tanzania. Please, Dr. Lejgov.
Thank you so much. So yeah, I'm Fabian. I have nothing to disclose. So just to sort of give some background, so world population today is almost 8 billion people. And according to the WHO, about half of those have limited access to medical imaging. So, and that just means diagnostic radiology. So obviously a lot more than that have no access to interventional radiology. So in sub-Saharan Africa alone, there are probably at least 1 billion people who don't have access to IR currently. Okay, so it's hard to imagine, but yeah, 1 billion people without access to even basic IR procedures. I'm going to be talking about Tanzania, which is located over here, but basically what I'm discussing applies to, as we could tell, Uganda and many other sub-Saharan countries. So this is not a unique situation in Tanzania. I went there for the first time 3 years ago in 2017 and did an assessment. So Tanzania is about 60 million people. At the time, there was not a single interventional radiologist in Tanzania, but there was availability of the necessary imaging equipment, and also they had a large diagnostic radiology training program with up to 20 trainees per year. So based on those findings and based on the urgent need for interventional radiology, so like I said, at the time, no one was even doing core needle biopsies, no one was doing nephrostomies, no one was doing biliary drains, let alone any embolization, so really nothing. Like people are basically just dying from urosepsis or biliary obstruction. So based on that urgent need, we said, okay, we're going to start an IR training program and focus on the training of residents, the training of nurses and techs, and improving the facilities and equipment. So the way we do this, we said, okay, instead of bringing Tanzanians to the US or to Europe, we're going to bring the trainers to Tanzania and try to establish the service and the training program in Tanzania. And the way we do this is by doing 2-week teaching trips on a monthly basis. So this is what the schedule looks like for those visiting teams when they get there. And so we started with the first teaching trip in October of 2018 with Douglas Sillen from Yale. And then sort of over the course of the following months, did 14 trips until February 2020, which is when COVID started. So you can see that, we've had people from all over North America, Yale, Emory, Cornell, Harvard, et cetera, someone from Canada. We've had nurses and technologists, mostly from North America, but some from Europe and one from Australia. So it's really been like a mixed group. So this is from the very first trip when we're going over. You can see us here bringing some equipment along. This is actually from the very first IR procedure we did in Tanzania. It was a biliary drain placement. And since then, we've really come a long way. So here you see some of the teams that have been to Tanzania over the course of the past 2 years. And here, this is Dr. Sonogo from Michigan. So he's the very last faculty that was there this February. Also, of course, there's room for extracurricular activities. So when people go there, usually over the weekend, they do a trip or something, either go on safari or go to Zanzibar. So this is Dr. Igor Latic from Yale enjoying a watermelon just outside of Zanzibar. And we've also made sure to involve the Tanzanian trainees in a lot of meetings when we still had real meetings. So this was in February in Dubai. I went there with Eric. This was in Boston a couple of years ago. This was SIR in Austin last year. So just for the timeline to give an overview, so I did the initial assessment in October 2017, and we started teaching trips in October of 2019. And like I said, we've had a total of 14 teams by now. In April of last year is when we submitted the curriculum. So just like Rosemary was saying, we had to submit a curriculum to the local university, which we did, and it took about half a year. So in October of last year, we got it approved. And October is also when the academic year in Tanzania starts. So that's when the first trainees enrolled in the training program, and this is a 2-year training program. It's called Masters of Science in Interventional Radiology. Okay, and this is the first IR training program in Tanzania, obviously, and in most of the region for that matter. So in terms of the practical training, the core of the training is of course practical training, and here's the schedule that we came up with for that. So we started in 2018 with procedures that we felt were most immediately needed. So that's sort of also coming back to your question, Rosa, what are the things that are most urgently needed? And, we figured that CT-guided biopsy and drainages is something that was, most immediately needed. Ultrasound-guided biopsy and drainages, nephrostomy placements, and biliary drain placements. And as you can see here, these procedures the trainees are now doing independently. So, this is after February, since there hasn't been any teams, and they're now able to do biliary drains, nephrostomies, and all of these other basic procedures independently already, which is, I think, a great testament to the training that they've received. Then in 2019, we moved on to other core IR procedures, including central venous access, splenic artery embolization, and uterine fibroid embolization, which, like Rosemary said, is a big deal in the region. Here's some of our outcomes. So as you can see here, for referring services, most of our patients get referred by surgery, followed by OB/GYN and GI. Here you can see the travel time to the hospital for most patients. So most are sort of, probably in Dar es Salaam, which is the biggest city in Tanzania, but some patients travel more than 24 hours. Okay, so it just shows that you have a country of 60 million people, and this is now the only IR service. So some people come all the way from, far regions of the country just to, have a procedure. We've done by now, I think, about 450 procedures, and here you can see a breakdown of the non-vascular and vascular procedures. So for non-vascular, it's been mostly corneal biopsies, GU and biliary procedures, and for vascular procedures, uterine fibroid embolization, catheters, splenic embolization, etc. We've treated patients all the way from 3 months of age to over 90 years of age. And here you can see the preferred means of payment. So this is a public hospital, but we try to capture all this data. So almost half of patients in Tanzania actually have insurance, while some do self-pay or get a hospital exemption. But like I said, it's a public hospital, so everyone gets treated one way or another. And then the plan for this year, of course, was to move on to complex procedures. But, so we were planning on starting like TIPS, TACE, more complex stuff. But then, of course, COVID happened, which is extremely unfortunate. So like I said, they've been continuing to doing some procedures that they're already proficient at, but then also we've tried to compensate by online teaching. So, participation in international conferences that are online, just like this one now. So they're following CERSI webinars. In addition to that, we have like 2 to 3 dedicated teaching sessions via Zoom per week with IR faculty that have been or will go to Tanzania. We're recording some VR training videos here at Yale. And then we're going to start live mentoring of cases via Zoom. So actually, we're sending a GoPro to Tanzania right now. It's like en route right now. And basically, they're just going to strap the GoPro to the head and do cases. And then they're going to have a faculty in the US that is watching them live via Zoom and can help them, if they need any assistance. So the major hurdles, not just in Tanzania, but in most of sub-Saharan Africa, for IR are, in my opinion, lack of baseline information, lack of knowledge, and then lack of industry support. And here's, I think, how we should address those. So lack of baseline information with Greg and some others, we're right now working on a letter to the WHO and asking them to provide us with more baseline information so that we can figure out how and where we can start more IR programs. Lack of knowledge needs to be addressed by training programs just like ours. So, this needs to be expanded, and I hope that many other programs, pop up in Uganda, Rwanda, Nigeria, etc., and because that's really the key thing. And then lack of industry support. Unfortunately, I don't really have a good answer. Like I've been fighting for 2 years and trying to get industry to supply products in Tanzania. And I'm not just talking about donations. So I'm talking about like we want to buy equipment. Okay, so this is the national hospital there. But most companies are not willing to sell their products. So the only two companies that I got so far to say they would deliver product to Tanzania are Argon and Merit. And I'm sure that Rosemary and Hamid can tell a similar story. It's extremely, extremely frustrating, and I think it's horrible that they're not selling their products. So in conclusion, we went from initial assessment last year to graduation of the first class next year in 4 years. I think this was really possible through strong academic collaboration between the university in Tanzania and then programs here in the US. I hope that the WHO and our other organizations can provide us with more data going forward. And I think the industry really needs to step up and accept the challenge. I understand it's not always easy to do business in Africa, but I think they just need to do it for the patient's sake, because right now, actually, just this week, we ran out of basic drainage catheters in Tanzania. So right now, nobody can even get a nephrostomy. And it's extremely frustrating because now the knowledge is there, so they can do the procedure, and technically, but now they don't have any drainage tubes. Okay, so then you have like young women with like metastatic cervical cancer dying from urosepsis, which is absolutely ridiculous. This should not happen. So you can read more about this in something we published in JVIR last year, and there should be a follow-up paper coming soon. And I want to thank the RSNA for their generous support. Sapphire, which I think is really going to be the key building block for IR in Africa. So that's the Society of African Interventional Radiology and Endovascular Therapy. And I think they can really unite interventional radiologists from all over Africa. I want to thank Muhimbili National Hospital and Muhimbili University of Health and Allied Sciences, Yale and Emory for their support. And you can find us online under Road to IR on Instagram and Twitter. Thank you so much.
Thanks, Fabian. Great stuff, man. Just a quick question for me. And if there are any interventional radiologists from Europe who would like to participate in this program, when obviously travel restrictions are lifted, how they can reach you? And, I mean, to start with, would you consider them, or it's only for the US people?
Of course, like I've actually been trying to get like some Germans or Swedish people. Like I'm a Swedish citizen, as you know. Been trying to find some Swedish and German people in particular, but obviously we're happy to take people from anywhere. I think the only prerequisite is really like a basic English skills, but I think that can be assumed from most people. So yeah, absolutely. And actually right now, because of all of those travel restrictions from the US, I'm actually also looking towards more people from the region. So I'm working right now on getting someone from Egypt to go to Tanzania. And then also Hamid, of course, from Nigeria. Like we're hoping that he can travel to Tanzania, because right now it's kind of difficult to get teams from the US there. So I'm hoping that we can do a little bit more local exchange. But yeah, I mean, anyone from Europe, obviously, they can email me or send me a DM on Twitter or Instagram, and I'm happy to arrange it. And like I said, we even have funding now, so I can actually pay for people's flights. Okay. So I can pay 4 flights per month. So like faculty, nurses, technologists, medical students, I can pay everyone's flights. So I think whoever wants to go should go.
Thanks, Fabian. Amazing work. I know how much time and effort you've put into this, and I think it's great to see how the service is developing. And I know COVID is slowing you down, but I'm sure you're going to get back to track when things are back to normal. And of course, as you said, the SRC and the SIR are working towards raising awareness around this, and we're preparing a letter to WHO, and we're also preparing a petition that hopefully is going to be signed by as many people as possible, really, to make sure that our voice is heard. Because at the moment, as Fabian said, WHO has a very poor understanding of how interventional radiology services work in those regions, and I think we should try and change that as much as as quickly as possible, really. Okay, I think we should move on now. Our next speaker is Dr. Hamed Ninalowo, who is a US trained interventional radiologist who is currently practicing in Nigeria. Welcome, Hamed.
Hey, thank you. First, I have to commend Fabian on the work he's done in Tanzania. Just the altruistic nature of the work you're doing there is absolutely commendable, and everything you've done, especially getting the funding is just amazing, and the organization also very, very, very good. Good work. So am I able to control the slides?
You should be able.
Okay. Do I just go? How do I move the slides?
Click the button, just click the right arrow. Like, I think you have to click on the screen first so that it's activated, and then you can click on the arrows.
Yeah.
Okay. Okay. Let's go back. Oh dear, I went back. All right, so my name is Hamed Ninalo. I'm a interventional radiologist. As Gregory said, I'm US trained, but I've had a lot of interest in, doing IR in my own country. So I started my own practice here a while ago, and I'll kind of tell you how that's going so far. So Nigeria, as you know, is probably the most populous country in Africa with over 200 million people. Even with diagnostic radiology, we still have a great shortage of diagnostic radiologists with less than 400 diagnostic radiologists, and a lot of them are actually still live in the country now and looking for a way to leave the country. Some of the diagnostic radiologists that were present were performing basic image-guided biopsies and drains, but mostly providing guidance to surgeons. So basically, a radiologist holding the ultrasound while a surgeon is doing a biopsy. So by 2018, when I started having interest in coming back to Nigeria, at that time they had basically one IR in the north who was somewhat formally trained in Europe and has come back to Nigeria, but has been frustrated in the north. And he trained about 3 other people in the north, and they were doing basic cases, and they've actually done some good work with fibroid embolizations and occasional arterial cases. But in the Southwest, there was no interventional radiologist. So basically in the Southwest, I'm the only interventional radiologist in the Southwest at this time. So as I said, in 2018, when I came and surveyed Nigeria as a whole, there were 3 functioning angio suites or cath labs, and these were all being used by cardiologists in the private settings. There were 3 cath labs in public institutions. However, they were all non-functional. There were less than 2 IRs with some formal training, as I said, and then the supply chain was essentially non-existent. When I started in Nigeria, my first interest was, going to public hospitals and doing IR as a collaboration with the government, but I was very quickly frustrated. And I wanted to do something that was impactful from the start. So I started this IR.Nigeria practice where I basically in 2018, I would spend 1 week in Nigeria and 6 weeks in the US. And I did this for about 1.5 years straight. So I would come to Nigeria, offer my services in this private institutions, a hospital called Urethral multi-specialty hospital here. They would book mostly elective cases for me. And I just started on doing complex work right away. And at that time, there was a good volume of cases. We would do about 30 cases in the week. Then we started a training collaboration with Rad also. And we initially started at Lagos University Teaching Hospital, and then we noticed things were just not moving so quick. Nigeria is a very peculiar place, as the government institutions really are just frustrating. Things just don't move as they do in most other countries. But then we moved on to University of Ibadan, where things were actually moving a little bit better. People were more enthusiastic. They wanted to get trained. But then I shifted a little bit to, I started inviting folks to come train in my private practice. And we've had a very good success story from that. Dr. Modele Olowoyeye, she trained with me in my practice and would show up every week for the first year I was here. And now she's in a fellowship in Canada, an IR fellowship in Canada, getting a formal training and hoping to also come back to Nigeria. So in September 2019, I decided, I really just wanted to be home and I wanted to practice IR more full-time here in Nigeria. And at that time, I had built a practice enough that I knew that if I spent 6 weeks in Nigeria and 2 weeks in the US, I could maintain some income. And, I knew I was taking a big risk, but I knew this was a service that was highly needed here. One of the biggest phone calls that I had was a patient that I had a arterial venous fistula in the liver, and I had just flown back to the US, and that patient was bleeding. And they called me and they said, where are you? And I said, I'm in the US. And the question was, what do we do now? So for me, that was an alarm bell as to, I could do more good at home and than abroad. So here in Nigeria today, the scope of IR is basically we offer everything in the practice and in some of the public institutions that we collaborate with, except for Y90 radioembolization. So the entire scope of interventional radiology is available and offered here. So when it came to practice building, and I'll just talk about IR in the private world a little bit here, we basically started from ground zero where nobody knew what we were doing at all. So the biggest thing was education, and more education. And we were just giving talks to every doctor that would listen to us. I knocked on every doctor's door that would listen. And then we started marketing services like UFEs, PAEs, venous ablations on places like Instagram. And quite honestly, we started getting more and more patients for things like UFE because the gynecologists here weren't sending us patients. They weren't interested in sending us patients because obviously that's a competitive specialty. And then the biggest thing that we realized very quickly was that we had to collaborate very closely with the surgeons. And there were a lot of surgical specialties that were quite advanced here in Nigeria, but they had no IR backup, and that was something we offered. And we basically went to convince them that they needed us essentially. So this is just one of the first cases this is September of 2018. This was my second case in Nigeria. My first case was a liver biopsy. The second case was an SVC syndrome at that time. I remember talking to my partners in my practice in America and told them I was going to go do an SVC syndrome case in Nigeria, and they told me I was crazy. Anyways, I got all the supplies we needed, and we came to do the case. We got IJ access, femoral access, and we were able to stent this patient and went from a big face the first day to a normal face the second day, and everyone was obviously excited. So that was how complex IR started. And then we got called about this young girl, and I don't know if this video is gonna play, who had bought Chiari and was draining 33 liters of fluid from her belly every week. I know, not every week, every 2 weeks she was draining 33 liters and basically had no hepatic veins. And we proceeded to do a butt Chiari tips here in Nigeria. I remember calling Ziv Haskell and told him I was going to go do a butt Chiari tips in Nigeria, and he told me I was crazy. But again, this case took 4 hours of a lot of struggling, but we got it done. And the young girl went from not going to school, being cachectic, carrying a big belly around, to going back to school and going back to somewhat of a normal life. I think that video is just gonna be very, very slow there. But again, as you can see, we had to put in a Viator stent graft, and then we had to put in a IVC stent graft side by side in order to accomplish this, because she had IVC stenosis. So I'll move on here. And then we didn't stop. We just basically kept going with the advanced cases. This was the first safari case in a diabetic foot on a toe also that was gonna get pulled, that was going to get cut off, and we recanalized the dorsalis pedis and the anterior tibial artery. This patient did very well. And then, we started telling surgery that they absolutely needed us. Things like transplants were being done in Nigeria. A lot of Indians were flying in, and some local doctors were doing renal transplants. And they would have these complications, but there was no one around to take care of these complications. So it's either they went back to surgery. For example, this case, as you see, there's a renal transplant there with a big pseudoaneurysm. They will go back to surgery and these patients will bleed out, or they offer the patients no options. So this is just one such case where someone called me and said, is this something you could take care of? And I had a conversation with a doctor in India. I was actually in America at this time. I flew back 2 days later, and we took this patient to the cath lab, went into the common femoral artery, saw the pseudoaneurysm. We covered it with a stent graft, and this patient did really well. We did save the transplant graft in this patient. So we continue to push very hard with the surgeons. This is just a case of a patient who had a guide wire that was lost in the IJ, and they were going to do a surgical cut down to go get it, until someone said, there's this IR guy, you might be able to get it. And they called me, and we snared this thing out, and everyone was just blown away that you could do that with just a pinhole. And that's what we've aimed to accomplish here, is just to show that we could do these complex things. This is a case of a urethral injury during a hysterectomy, where a urologist had tried to go from below to stent this patient. They couldn't, and I said, we could do this together collaboratively. I will come from the top, you come from below. So we went from the top. I couldn't cross from the top. He couldn't cross from below, and then I gave him basically a Rocher sheet and needle. I put a sheet in from his access, and I said, basically stick me with this needle that I've just given you, and he basically started stuck it, put a wire in, and we were through and through, and this patient was stented, never had to go to surgery, and I'm actually removing the stent for this patient in about a month or so. And then we started plugging holes in services that just were not available, like complex GI. We don't have ERCP here. We have one center that does ERCP somewhere in the Southwest, and the skill level is still very, very poor. So we knew that things like biliary stents were highly needed. And we started providing the services for patients that needed palliative stenting, or there's patients that need biliary stents in general. We also performed biopsies, brush biopsies for these patients. And the service has grown. As a matter of fact, I did a biliary stent just this morning. And then we started getting into things that, we were more and more complex. I invited folks from the US. This is Scott McLafferty with Rad Aid, and this is one of the Rad Aid trips where we did the first prostate artery embolization here in Nigeria. And this was a 330-gram prostate with a guy that was walking around with a Foley catheter for about 2 years, and this guy was able to get that Foley catheter removed 3 weeks later after prostate artery embolization. And so we continue to tell these stories, and we still have the trainees that get excited from the public institutions. But the people have also asked me, like, why would you leave your practice in the US to go to Nigeria, and why are you here? And this case, I bring out this case, and I think this is the last case I'm going to show, is the reason why we're here. This was a 26-year-old guy that presented to me in the peak of the COVID period. And he'd had upper GI bleeding for the last 2 months, just recurrent, being transfused, severely cachectic, and had this splenic artery aneurysm, hepatic artery aneurysm that basically connected to the left portal vein that turned into this left portal vein aneurysm. And if the CT plays here, you would see the left hepatic artery has this calcified aneurysm that basically feeds into the left portal vein, and there's this giant aneurysm in the left portal vein, and there's arterialization of the entire portal system. So basically, the pressures in the portal system were basically systemic arterial pressures, which explained why it was bleeding. Excuse me. If this video will play here, this is the angiogram from the hepatic artery. Let's see if the other one plays here. But what you would see here is the aneurysm feeding directly into the portal vein, and there's basically complete hepatofibril flow in the portal vein. And what you notice also is the celiac artery is as big as the aorta in this case, and I should have demonstrated that on the CT. Anyways, we did a plug embolization and put in coils in that left hepatic artery. And this young man, 2 months later, is basically gained weight appropriately, is now bled since, and is back to school and back to living a regular life. So we continue to strive, and this is just a follow-up CT scan on that patient, showing that there's complete occlusion of that left portal vein aneurysm. This is another case of a patient that ruptured an HCC in the COVID period, and this is his 4-month follow-up CT scan with the mass that was initially about 7 centimeters, now about 4-point-something centimeters, and also doing very well. So the challenges that we face here are that we're in a very resource poor environment, and every supply that I use here, I basically have to source either from China, from India, or from the US. And I've created this supply chain where, quite honestly, it's not completely, legit, as Fabian would say, because I've had to basically use my networks to get all the supplies that I need. But one thing I've done very well so far is I've invested a lot of my own money into the practice. I've not really depended on any hospital to provide supplies to me. I basically try to depend on myself to provide all this supplies. And the biggest things we also need are increasing awareness and continue to increase awareness and basically make a lot of noise. And again, training. As I said, my biggest success story so far is a girl that, spent some time with me, and now she's in Canada, and she's hoping to come back to Nigeria very soon. But the supply chain is a very, very big frustrating thing. As Fabian said, we've reached out to a lot of these companies and begged. And you can understand some of their points. They still do not have a big end user, a big pool of end users. So they're not going to be making any money if they came to Africa now, or this part of Africa anyways. It would be a lot of philanthropy And we understand that, but they also have to understand that we're trying to do something and we're trying our best, and they just have to come to the table and help us. But again, I really believe that IR is key to moving medicine forward here in sub-Saharan Africa, and we just continue. We just have to continue to persevere. Thank you.
Thank you, and thank you for your interesting cases. Are there any questions? No.
I had one question. Hamid, like, how many interventional radiologists do you think Nigeria needs? Or like, what would be like a good number?
At least 200.
Okay.
At least 200.
One per million at least.
Correct.
Okay.
But we're making strides. You know, now we have the Nigerian Society of Interventional Radiology. We're collaborating more with the guys in the north and the guys in the south. And, you know, we're starting to have more and more meetings. And hopefully what we're trying to do soon, hopefully, is to create a formal training program here in Nigeria. Again, that's very difficult, where in most public institutions, the supplies are not there. And then most importantly, the capital equipment always break down, and they're just not maintained in this part of the world. So I really believe the way to move forward is still going to be the private practices and the guys that basically come to the private practices to come train. And we just need to find a way to collaborate between the private practices and the public institutions and the academic institutions. But again, Nigeria is a very interesting place in that, you know, people are not very collaborative in that sense. But I think, you know, people would soon understand that the only way forward is collaboration, and that's just what we have to do.
Yeah. One more quick question. Do you get any reimbursement through insurance? Like, do insurance companies in Nigeria accept any of these treatments?
Yes. So basically, we do get reimbursements, but they're not specific IR codes. Basically, we give them a price, and they basically say yes or no to most of these procedures. But most of the procedures that are reimbursed by insurance companies are procedures that cannot be done by any other specialty. So for example, the arterial portal fistula that I just showed you, that was a case I did for free because the patient couldn't afford anything, right? So there are cases, so I have a foundation here where basically I just have to find a way to fund those cases. And then I fund it through basically donations from friends, and I donate my professional fees, or I just donate everything. So it's very, very difficult to make it work here. And as you know, everything we use is very expensive, right? And we still need to think about, you know, sourcing supplies from places like China and India, because that's the only way forward. The US supply chain is just too expensive for this environment.
Have you received any help from the industry so far?
No, I've received help from, you know, basically the low guys in the industry. Basically, I have a lot of reps that I used to use in my practice in America who help me out, who, you know, sometimes would basically donate some supplies here and there. But as far as major industry help, no. Merit and Argon, as Fabian said, have said they would give us a supply chain. They would give us someone to buy from. Till today, I still don't have that contact. I've called them multiple times. I've emailed multiple times. They just say, yo, we're working on it. And they still have not given us a contact to buy from.
I think that's a big problem, isn't it? Okay.
Absolutely.
Thanks, Ahmed.
Thank you. Now we can move on to the next speaker, that is Andrew Kesselman. He is involved in the non-profit organization Readiness International, and he is talking about the Readiness and IR. Please, Dr. Kesselman.
Hi, everyone. I appreciate this opportunity to talk to you guys about RAD-8 and our IR program. Let me see if I can advance these slides. There we go. So those are some great talks, and you know, I really appreciate all the amazing work that everybody's been doing. I am a volunteer at RAD-8 International, and also a interventional radiologist here in New York City at Weill Cornell. So I put a lot on the agenda for this talk. I wanted to give an overview of our RAD-8 IR program. I wanted to talk about training involvement in global IR, and then I wanted to talk about a particular interest of mine, which is simulation and global IR outreach. And hopefully I can get through all of this in 10 minutes. So just to start, I think others have heard me say this before, but about 50% of the world lacks access to radiology services. About 50% of conditions rely on medical imaging for proper diagnosis. And increased use of medical imaging is directly tied to increased life expectancy. And with those things in mind, Radiator International was founded in 2008 to increase and improve radiology for medically underserved countries. It's grown to become a large organization of greater than 10,000 volunteers with on-site programs in over 30 countries. And we started our small IR program in 2017 with Radiator volunteers like myself. One of our basic tenets is this Radiator readiness assessment. We do this at our sites, and similar to a needs assessment, but rather than looking at exact needs at the sites, it looks at what they're ready for and what they currently have available. We have a particular needs assessment based on the IR program. So for our IR program, the main goals were to increase access to interventional services in underserved regions and to coordinate IR outreach endeavors. We wanted to increase awareness of interventional radiology globally and help develop dedicated IR training programs at international sites. And that was a main focus for us. In terms of sites, so we have Kenya, Vietnam, Ethiopia, Ghana, Nigeria, amongst others. And then we have RADAID diagnostic sites all over the world. As you heard others people mention, there's no shortage of challenges in doing this kind of work. This article in JVR in 2019 kind of categorized a bunch of them into different categories. And I think you have to consider most, if not all of these, when trying to create sustainable efforts in low to middle income countries. So our focus has mainly been on education. We have some training models that involve residents, also IR fellowships overseas. And we've come up with some novel training methods. We have the global IR curriculum and a learning management system. We have an endovascular simulator and a curriculum related to that. We have IR webinars and symposiums, and we have VR training videos and curated content guides. Some updates for 2020. We have recent approval of our dedicated IR fellowship in Kenya. There's 2 fellows that'll And RADAID is there to help support educational goals with our in-country stakeholders. And we have site MOUs with the University of Nairobi and Aga Khan for this. So pre-COVID, we were sending IR deployment teams. These were multidisciplinary. And, Fabian hinted at this as being a really good approach to kind of getting that education across. And we send attendings, trainees, nurses, and techs as a group whenever we can. They perform didactics and various involvements in clinical work, and they work collaboratively to reinforce best practices with those in country. This is a group that went out to Vietnam. So what are some considerations when doing these deployments? Well, I think practicing medicine in low to middle income countries requires cultural sensitivity, patience, and a bit of ingenuity. Volunteers encounter both cultural and technical differences in practice. To make the most of your experience when you go, it's best to prepare educational objectives tailored to the local practice, keep an open mind and stay flexible, as unique opportunities may present themselves while in country. And at RADAID, we have a track record in transparency. We prepare our volunteers and set them up to succeed. And I think other organizations also mentioned here do a very good job of kind of getting those efforts to their volunteers. Others spoke about IR procurement, and I won't talk much more about it because it's been a struggle for us, and I haven't made much progress in that. But I think what we see at most of our partner sites is constraints with consumables, and that leads to necessitating careful use of the limited available inventory, and I think you heard about that as well. We do try to help, though. We have procurement materials, a toolkit, and resources that we make available to sites. We try to help with equipment service contract support and purchasing guidance. But that's best done prior to purchasing. Once the equipment's in, it's kind of hard to help after that. We've worked on charitable grant programs with Cook and other vendors, but again, those are limited. We're encouraging local and regional development of tech and consumables. And we do have some management and logistics of donated supplies to us that we try to get out to countries. And we have a recent collaboration with High IQ, so we'll see how that progresses. I think it's really important. I think the other speakers kind of hinted at this to have good collaboration and partnerships, kind of to strengthen what we can do and leverage all of our resources together. We work with the SIR, Mantis, Cook, High IQ, Burlington, just to mention a couple. And I think really important other ones are AARON and the ASRT that RADAID has partnerships with, which are the tech and the nursing organizations. Here are just some example, some photos from work being done by volunteers in Vietnam. This is in the central region of Vietnam in Da Nang. Here you can see them doing biliary drainage there. This is in Kenya. These are one of the most recent trips out. This is a few images of volunteers out in Ethiopia. On the right, you can see some nurses undergoing some education there. This is in Nigeria, where they did a symposium. And then I wanted to touch upon what's going on now in the COVID era. So deployments are on hold for us. I'm hopeful that we can start in 2021, but there's a lot of uncertainty, even where I live here in New York City. So it's really hard to predict. And we want our volunteers to be safe, but we also want to see if we can continue with efforts that we've been kind of started. There's been a shift to IR webinars and remote symposiums. We've been building a novel learning management system with encounter-based modules that we're hoping to offer to our sites. We're hoping to start a virtual angio club to coincide with the Kenya IR Fellowship. And we have plans for more small group live simulation cases with remote proctoring that we're working on. Okay, so now I'm going to shift focus and talk about training involvement in global IR, because I think there's a couple of trainees here. We have the Readiness annual meeting. It's virtual this year, but it's usually held in person in Washington, DC at the PAHO building. There's presentations from different sites and programs, and it's a great opportunity to network and make new connections and hear about what's going on within our efforts. Why participate in global IR outreach in general? Well, there's significant opportunities for IRs to make an impact in global health. You can help address disparities in access to interventional services worldwide, and participation has the potential benefit to increase professional fulfillment and decrease burnout. I get asked a lot about trainee funding opportunities. The main one we have is with SIR. They provided funding with us for members that serve on our RAD-A teams, but there's additional opportunities out there. I think Fabian's group has funding opportunities, and there's other ones listed on the RFS page that's dedicated to international outreach. So they've been compiling those. In terms of in-country opportunities for trainees when they go over, well, there's hands-on with attendings and overseas trainees for procedures. There's didactics that you can definitely participate in. There's symposium setup and simulator use, which I think has been very helpful. Performance of new IR readiness assessments is really helpful because we're not in every country, obviously, and we've been very selective on where we do our outreach, but it'd be helpful to have these assessments to know what's going on in some of the other sites. Coordinating and logistics on donations is very helpful, and then QA department workflow projects can also be helpful opportunities. How do you get involved with us? Well, if you sign up on our portal, you'll get updates, and you'll actually get somebody reaching out from our team to establish kind of a relationship with the RAD-A program managers for site specifics. And then we'll work with you and your institution to hopefully that you can work on getting elective time approved so you can go out on one of the deployment trips when they start. This is where on our website where you can click to sign up on our portal, and you'll get somebody to reach out to you pretty soon after that. And then lastly, I want to touch on simulation and global IR outreach because this is a particular interest of mine. So we started a collaboration with Mantis in January 2019, focusing on simulation curriculum development overseas sites. Procedural simulation allows trainees to gain familiarity with equipment, learn key procedural steps, and practice technical skills in a risk-free environment. So why is this useful, simulation and global IR outreach? Well, there's a definite lack of consumables, right? And that leads to decreased amount of procedures that can be performed by operators, and that leads to downstream to decreased training exposure and competency. And the benefit of high fidelity simulation is it decreases the need for consumables to gain experience, comfort, and competency. But there are challenges with starting a simulation program, right? The initial costs can be very high. So we have a donated unit as part of this, this collaboration with Mantis and continued support from them. And we also use donated supplies. So that's worked out for us. And in terms of travel, it rotates between the different IR sites with volunteers. We actually have them carry it with their check-in. And then we ship it within the US, different volunteers via FedEx. So what are these high fidelity endovascular simulators? Well, they provide a hands-on experience of endovascular procedures in a simulated environment. They have modules ranging from peripheral angio to complex aortic interventions. The benefits are they're reproducible for objective evaluations, and there's no increased need for disposables. And the considerations for us when we're looking at one of these units was that it needed to be portable, durable, and provide a realistic experience. So this is the Mantis VIS G5 simulator. It's just one of many different types of high fidelity simulators that are out there, but the one that we particularly use. It's low footprint. It packs into 2 flight cases for check-in. It supports real clinical devices, so you use real wires, catheters in this unit, just with small minimal modification. Right now, there's 20 procedural modules, including uterine artery embolization and vascular trauma management, which I think are important to a lot of our sites. And we're working with Mantis actually to build 2 new modules on bronchial artery embolization and GI bleeding, which I think will be very important for sites. We have a curriculum based off the simulator. It's with didactics from radiated volunteers. It uses the modules built into the Mantis unit. There's 4 levels of increasing difficulty. We can track metrics on the different users. There's suggested readings that go along with each level. And I just mentioned there's plans to add those new modules with Mantis. And we also have VR simulation videos. I think Fabian said he's been working on that as well. They're created in our simulation lab, and it allows trainees to use VR goggles to enter into the procedure along with us. This one on the picture here is a demonstration of the IVC filter placement one, and they're available on our Radiate IR YouTube channel to everybody. And we just filmed 3 more, so those will be coming up shortly. These are some examples of the simulation workshops that we've done overseas. Here's in Vietnam and Kenya, and you can see some of the setup there. And we recently did a web-based IR symposium and simulation session because we couldn't travel because of COVID in Kenya. It was a combination of didactics and simulated cases using the Mantis and webcams. And we did QA and small breakout sessions, which were pretty well received. And in the middle here, you can see I did a demonstration of venous stenting using the simulator. So just some take-home points. Radiate IR is dedicated to increasing access and global awareness of interventional services. We hope to create sustainable training programs, making a lasting difference in the global medical landscape. And in my opinion, vascular simulators offer a variety of opportunities in global IR outreach. This is my email. Feel free to reach out to me. And I appreciate everybody's work and your time.
Thanks, Andrew. That was great. I think I would definitely prompt people to visit Radiate's website and have a look at what you're offering and the work you've been doing in Africa. I also think that the work that you have been doing with Mantis is very important. I think that more companies should follow Mantis' example and contribute to this cause. I think it's of paramount importance to get involved, to include the industry, the societies, and the physicians into this effort. I think we could stay here and talk about this the whole night. I'm sure that Fabian could keep us all busy here, but I'm well aware that we are running out of time a bit. So any final comments or remarks, anything that you'd like to add, guys, or any questions for Andrew? No? Okay. So that's great. I think that I'm pretty sure they're going to hear more and more about this topic in the years to come. And I'm very glad to see that there is so much progress in this. I think there's no doubt that there's a huge need in Africa and in other low-income countries. So we don't only speak about Africa. But we have to start from somewhere, and I think the key for this is collaboration, and we need to make sure that we all keep talking to each other, and that the big societies like CERSI and SIR and Radiate, they keep talking to each other and they keep collaborating. It's definitely not a task that one person can tackle. I mean, we need everybody to get involved. We need as many hands on deck as possible. Rosa, any final comments?
It's a very interesting session. I'm not. I don't know enough about this word, about this organization, and I'm amazing of your effort in this task. It's amazing what you are doing. So I think that our time is finished, and I want to thank you, all of you, for participating today in this very stimulating session. And thank you for your content and for all. Thank you.
Thank you. Enjoy your evening or your day. Take care. Bye bye.
Thank you, everybody.